Pathology, inflammation. All right, so first, to understand inflammation and what's going on, we have to define it. And all inflammation is just a response by our immune system to eliminate any initial cause of cell injury or cell death. Okay, so that's what inflammation is. It's our own response, okay, which is so odd to think about because you think as inflammation is hurting ourselves. But in reality, what's occurring is that we are just responding to something that's hurting our cells, causing cell injury or cell death. And then it leads to an inflammatory response due to the fact that we have white blood cells that release cytokines and other things that modulate inflammation, okay? So just to begin with, it's just our immune response to something attacking our cells, making them injured. Okay, now, it can be a good thing and it can be a bad thing. It's separated into acute and chronic inflammation. However, when it usually leads into chronic inflammation, that means we've kind of progressed into a stage that we don't really want to be a part of. But acute inflammation is kind of that beginning process. And all acute inflammation is characterized by is if we have the presence of neutrophils in the peripheral tissue, okay? So neutrophils, usually associated with edema, means that we are in a state of acute inflammation, okay? It's usually rapidly onset, and it's a part of that innate immune response, which we'll talk more about in the immunosection. But it can be stimulated by multiple factors because there's so many things that need to mediate acute inflammation. So let's start with the first one. The first one is TLRs, okay, or toll-like receptors. Toll-like receptors are just receptors that are on our white blood cells, okay? And they recognize these things known as PAMPs, okay, which are located on invaders, okay? Once our TLRs, or toll-like receptors, recognize these PAMPs on these invaders, our immune system activates or releases, our white blood cells release NF-kappa B, which mediates our immune response, triggering an increase in the amount of white blood cells that need to be in that area. Okay, so that's the first and foremost thing that occurs for acute inflammation, okay? Another mediator of acute inflammation is known as phospholipase A2, PLA2. And we're going to talk about this a little more later on in other chapters, but this whole entire pathway is very, very important. So PLA2, phospholipase A2, is going to release this thing known as arachidonic acid, okay? And arachidonic acid can go down two separate pathways. It could form COX, okay, the COX pathway, or it could go down the 5-lipoxygenase pathway. Let's start off with the COX pathway because we discussed it for the hematology oncology videos. So the COX pathway is going to form and produce prostaglandins. And prostaglandins are important in any vasodilation and permeability, okay? What you need to know specifically is that PGE2 mediates fever. Prostaglandins also are going to be protective for our mucosal linings, all right? So that's an important thing that you need to keep in mind. On the other side, arachidonic acid can produce 5-lipoxygenase, as we said. 5-lipoxygenase can produce leukotrienes, okay? And the leukotriene that we specifically need to know about is LTB4, which does neutrophil attraction, okay? And while we're talking about neutrophil attraction, there are other mediators that attract neutrophils that we must know. So one, we already talked about it, is LTB4. Number two is going to be our IL-8 from white blood cells. Okay, they release IL-8, which attract neutrophils, okay? And last is our C5a, which is a part of our complement system. Okay, so C5a, IL-8, and LTB4 are the most important chemo-attractive factors that attract our neutrophils mainly. Another mediator of our acute inflammation is going to be mast cells. What mast cells do are usually in response to, I would say, like allergic reactions. What they're going to do is cross-link IgE and activate it, which is one of our antibodies. And lastly, our last mediator are the complements. And the complements are activated via IgG and IgM in our classical pathway. And the other pathways aren't really as important. So just to go over them really quickly, the acute inflammatory mediators are TLRs, toll-like receptors, phospholipase A2, PLA2, which produces arachidonic acid and can go down the COX pathway or the leukotriene pathway. Mast cells, usually mainly for our allergic reaction response, and then our complement pathway, all right? And then after we've cleared the infection or the invader in which what was going on that caused the acute inflammation in the first place, we're going to have macrophages come in and essentially phagocytose all of the dead neutrophils, okay? And what macrophages can do now is that they can sense the environment and see if there still is an ongoing issue. If there's not an ongoing issue, what the macrophages will do is they will release IL-10 and TGF-beta, which causes the calming of the immune system, or they can decide to persist the inflammation and lead into chronic inflammation. All right. So those are the kind of key concepts that go into acute inflammation that you really truly need to know. And we're going to go further in depth on what's going on, I guess, at the cellular level in the immuno chapter. But this is all you need to know. Now, the question is, for acute inflammation, how do we get the neutrophils out of the blood and into the peripheral tissue? This process is known as leukocyte extravasation, and it's very high yield to understand this process. So if you have any questions, make sure to ask and spend most of your time on this because it's really important. Okay, so extravasation usually occurs at post-capillary venules. Okay, that's where we're going to have usually the leakage of our white blood cells, specifically our neutrophils, out into the peripheral tissue from the vasculature. Okay, the first step is margination and rolling. Okay, so how I do it, I start off, it's rolling. So we have these neutrophils that are flying through the blood, okay? We need to have some type of speed bumps to slow them down. And this is what we call rolling, okay? So rolling the cells is gonna help them slow down, and they're gonna become closer and closer to the cellular wall in order to attach onto something later on, okay? So that's the first aspect, rolling. And it's usually done by E-selectin or P-selectin, okay? Very easy and simple. Next, we have adhesion, okay? And adhesion takes place due to ICAM or VCAM. And the reason we're able to do that is because we have this thing known as CD18, which binds our VCAM or ICAM in order to get us attached or adhesed to the capillary wall, the endothelium, okay? Now, there's this thing known as, a pathology associated with this, is leukocyte adhesion deficiency type 1, LAD type 1. And this is very, very high yield because in LAD type 1, we have a decrease in CD18, which is also a decrease known as a decrease in integrins. And those integrins, CD18, usually bind the ICAM and the VCAM, right, to help us attach to that endothelium. Well, if we have a decrease in CD18 or integrins, known as LAD1, the patient's going to have issues getting the neutrophils out of circulation and putting them into the peripheral tissue. So the normal presentation is going to be delayed umbilical cord healing, which means that the umbilical cord will still be there. It's not going to be fully healed even after 30 days. Before 30 days, it's not abnormal, okay? But after 30 days, then it's considered delayed umbilical cord healing, okay? 30 days after birth, obviously. Secondly, you're going to see a bacterial infection with no pus because all pus is just the dead neutrophils in our peripheral tissue. Well, if we have bacterial infection and there's no neutrophils because they can't get out of the blood due to the fact that they can't do the adhesion portion because of our loss of CD18 and integrins, then we have no pus, okay? So keep that in mind. It's a pathological association that they like to associate with adhesion. Next is this thing known as diapedesis or transmigration. This is finally the pulling of the red blood cell or of the white blood cell out of circulation and into the peripheral tissue, okay? We need PCAM, PECAM to do transmigration, okay? Lastly is migration. How do the cells know where to go once out of the blood? And this is helpful for our chemotaxic agents known as C5a, IL-8, and LTB4. We already talked about them. I just told you what they are, but I'm going to review them again because they're so high yield. C5a, IL-8, and LTB4 are really going to help us get our neutrophils to the site of action where they need to be. Okay, so understanding acute inflammation and leukocyte extravasation is very important to understanding the full idea of what occurs in the pathology chapter. Okay.